Hello, and welcome again to the Clinics Review Articles podcast. Thanks for listening. I'm John Vasallo, the Managing Editor for Surgical Clinics of North America here at Elsevier. Surgical Clinics is a bi-monthly publication consisting of review articles centered on a central topic important to general surgeons. Our consulting editor is Dr. Ron Martin of York Hospital in York, Maine. In this podcast, we will be discussing a recent issue on emergency pediatric surgery, and joining us are the guest editors of this issue, Drs. Todd Ponsky and Aaron Garrison, both from Akron Children's Hospital in Akron, Ohio. Gentlemen, welcome.
Thank you.
Thanks.
So, why an issue on emergency pediatric surgery and not one on simply pediatric surgery?
Well, pediatric surgery is a broad specialty, and there's a lot to discuss about elective care and emergency care, but it's a unique specialty in that a lot of what we do is emergent, probably more so than the adult world. And we thought it was an important issue to have because this is something that you may not have time to go do a lot of research on before an emergency case. This is the type of thing to read ahead of time, get used to the information, know it, so you can be prepared when you have an emergency situation.
What were some of the goals you wanted to accomplish with this issue?
The primary goal is to make sure that the surgeons around the country and around the world are really up to date with the changing standards of care. This is a specialty that's probably moving faster than most, and what might have been current a few years ago is not current today. So we wanted to make sure that people were up to date with how we should be managing these emergency situations.
There are 15 articles in this issue, but we're going to focus on 4 of them. The first article I would like to look at is Non-Accidental Trauma in Pediatric Surgery, authored by Drs. Paul Kim and Richard Falcone, Jr. What are the most common traumas they write about in this article?
The most common trauma that we see in non-accidental trauma is usually head trauma. It's usually in the toddler type ages, but really it's a very broad category in that you can see burns, you can see fractures, and I think the main take-home message from the chapter is really to maintain a high index of suspicion anytime you encounter a child with traumatic injuries.
Can you take us through some of the clinical presentations and what the surgeons should look for?
Sometimes it's very difficult to ascertain if a patient is a victim of non-accidental trauma. Of course, the parents never come in telling you that they abused their child. The surgeon has to have a very high index of suspicion and be prepared of what to look for. For example, a newborn baby or a baby that's under 6 months of age rarely has a significant fall from a crib or something like that causes an injury. So if a child comes in that's under 6 months of age that has a head injury, we should always be under high index of suspicion that this is abuse.
And I think another point that Dr. Falcone has published on before is that setting a standard protocol for screening as far as which injuries may be more likely to be related to non-accidental trauma really is something that all trauma centers should strive to do to try to take out some of the implicit bias that we have in taking care of these patients.
The authors mention a screening protocol for possible abuse at the end of the article. Can you provide some detail on what the protocol is and how it should be implemented?
Each hospital has their own criteria, but by establishing certain mechanisms and injuries, whether or not the injury was witnessed or not, really kind of leads to whether you're going to perform a skeletal survey or more advanced imaging on patients.
This important article devotes quite a bit of text to the major issue of child abuse. One study showed that pediatric surgeons were consulted in only 56% of the cases. Why do you think that is?
I think many times it's not apparent that it's actually abuse until later on in the course. And so perhaps up front, surgeons aren't consulted, but people with a high index of suspicion stay on it, and ultimately the surgeons get involved later than is ideal.
John, the major take-home point from all of this is that we used to think we could tell who was a victim of child abuse. We used to use socioeconomic biases that would allow us to believe that maybe this was a victim of abuse. For example, if it was a young couple, young parent couple, if it was the baby was alone with the babysitter or the boyfriend of the mother, we used to make these assumptions that what Dr. Falcone is showing is just wrong, that we really are really bad at predicting who is a victim of child abuse. And so what his protocol in general states is that you need to have a standardization, whatever it is at your institution, of working up any potential child abuse. And every institution has a different mechanism by involving social work or even at some point child protective services. But the main take-home point is to ignore any biases you have and have a set protocol, and every child, no matter who they are, undergoes the exact same workup.
That's an excellent point. Let's move on to the second article. I would like to discuss intestinal rotation abnormalities in midgut volvulus by Dr. Jacob Langer.
Well, it can vary whether it's an acute presentation or whether it's a more chronic presentation. Acutely, the sign that we're all taught to really fear is bilious or green vomiting, and that is a sign that anyone who takes care of children should have a concern for malrotation and potentially volvulus. We do sometimes see patients in the clinic, however, who have more chronic symptoms, maybe just some spitting up, failure to thrive, and those patients are also at risk of may also have malrotation requiring surgery, but it's not as dramatic or as urgent as acute volvulus. I think what I really liked about this chapter is Dr. Langer gives a good guideline for how to deal with the patients who are kind of in between, patients who may have an atypical upper GI study but not obviously volvulized.
He also mentions a gold standard for the diagnosis of a rotation abnormality. Can you go through that?
So the gold standard is going to be an upper GI. There's been an evolution of diagnostic modalities to try to figure out rotational anomalies. They used to do contrast enemas or barium enemas to see where the cecum was located. We can even tell from ultrasound, you can tell suggestions of malposition of the mesenteric vessels or even a CAT scan. But without question, the gold standard is an upper GI study evaluating the C-loop of the duodenum to make sure that the duodenum not only crosses midline, but also the fourth portion of the duodenum rises back up to the level of the pylorus. Any anomaly in that C-loop is an alarm to the surgeon that this may be a rotational anomaly and requires investigation.
What are some pearls regarding the upper GI study that surgeons should know about?
Number one, you have to have an adequate amount of contrast so that you can get an adequate study and follow it all the way through. Number two is that you have to make sure that the third portion of the duodenum starts on the right side of the abdomen and crosses midline over to the left side of the abdomen. So it has to cross over the spine. And then also you have to make sure that the fourth portion rises up to the level of the pylorus. It also is a study to help evaluate for a volvulus, which has to be separated from the concept of malrotation. So malrotation is just an abnormal rotation of the intestines, and most people can go their whole life without a problem. But sometimes this can lead to a twist or a volvulus. The upper GI is also helpful in diagnosing the volvulus separate from the malrotation. So if the contrast goes from the mouth all the way down to the colon, it is unlikely that there's a volvulus, although it is possible to have a volvulus and contrast pass through it without a complete obstruction. Usually they look for something like what's called a bird's beak that would signify that there's an acute point obstruction from a volvulus.
Can you take us through the operative correction of malrotation? This involves the LAD procedure, correct?
The standard of care right now for the treatment of malrotation is something called the LADS procedure. This is named after Dr. William Ladd, who is the founding father of pediatric surgery and described this procedure. What Dr. Ladd described was that the idea of trying to separate the mesentery as much as possible, to have the two ends of the mesentery being the first part of the jejunum and the other end of the mesentery being the ileocecal valve. The two of those being as far apart from each other as possible and making sure that the mesentery is completely separated and splayed out. The way he accomplished this was by first dividing these bands called Ladd's bands, which run across the duodenum from the cecum, and by dividing those allows for separation of the cecum from the duodenum, and also allows for separation of the mesentery. He did not mention the idea of taking out the appendix, but that was added later on as an addition to his operation because the appendix would be in an abnormal location, and the thought was that we should take out the appendix in case the patient eventually presents with appendicitis. It may be a tricky diagnosis because it wouldn't be in the typical right lower quadrant locations. We have to keep in mind that these patients will always be malrotated. The Ladd's procedure does not unmalrotate someone. We can't undo that. All we can do is separate things as much as we can to minimize the chance of them getting a volvulus in the future. The key thing that's in controversy in today's era is whether or not this operation can be done laparoscopically. This is a very heavily debated area because some people believe that laparoscopy doesn't cause enough adhesions to keep things fixated away from each other, and that by having adhesions from an open operation, it's less likely for things to move around and twist. This is yet to be proven, and more people are moving towards the laparoscopic procedure as we are finding that it does not portend a worse prognosis.
Those controversies are also mentioned in the article, so thanks for mentioning them. I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert. Next up is the article on pediatric ovarian torsion by Drs. Krista Childress and Jennifer Dietrich. This type of torsion is rare, but does account for 2.7% of all cases of abdominal pain in children and adolescents, and is the fifth most common gynecologic emergency. What other key points about this type of torsion should the general surgeon know?
I think by far the key point and the take-home message for this is that we're really in a place of ovarian salvage here, meaning that we used to, if we were operating on ovarian torsion and we identified a necrotic ovary that was black or blue and looked bad, in the past people would remove that ovary. And what they found and people are encouraged to do now is just detorse the ovary, untwist it, and that some of those germ cells and stem cells in the ovary will actually survive. And that in the past we may have been removing ovaries that were not actually dead. So I think anyone who's taking care of emergencies should know that ovarian torsion in children should be initially treated with a detorsion and not a resection unless you're concerned about some type of malignancy.
Dr. Ponsky, anything you wanted to mention?
So you brought up a good point about the general surgeon. This is one of those diagnoses that may often be identified by a general surgeon. And one thing that's key to point out is when to operate. And sometimes it's very difficult to tell an adolescent girl who just happens to have a regular old ovarian cyst from one who's torsed. Unfortunately, John, we don't have a good diagnostic study to diagnose torsion. We have ultrasound, which can give us suggestion of it, but unfortunately, it cannot rule it out. So an ultrasound that shows good blood flow to the ovary does not mean that the patient does not have torsion. This is probably one of the most important points to make. You cannot go home and go to sleep with a girl who has acute onset of abdominal pain with a large ovarian cyst over 5 or 6 centimeters. That pretty much mandates a trip to the operating room if they have an acute onset of pain with a large ovarian cyst. You cannot rely on ultrasound to tell you that there's no torsion. The only diagnostic test is a laparoscope to take a look inside and see.
Can you go into a little bit more detail on the management strategies?
So the management strategy is to go in laparoscopically, usually. If you can't, then you could do it open. But go in, untwist the ovary, and no matter how black it looks, leave it in. We do not like to take out ovaries because you'll be surprised that they'll still have ovarian follicles. I then believe that the patient should be followed with serial ultrasounds post-operatively to make sure that this is not a tumor that's growing, that this cyst size should decrease over time. There's a debate about what to do with this cyst. Should we just drain it? Should we resect it? Should we unroof it? A lot of times it's a hemorrhagic ovarian cyst, and you really can't get rid of all of the mass effect. Some people just open it to let some of the blood out. Some people excise the cyst. Some people think that you shouldn't do that because it could be a tumor. That's under debate, and we still don't have a really good answer about that. But the main tenet is to go in anytime a girl has acute onset of pain with a cyst greater than 5 or 6 centimeters, that an ultrasound can't rule it out, untwist the ovary, try not to resect the ovary, and get a follow-up serial ultrasounds, and if any question, refer to a gynecologist.
What's the prognosis? Can the ovary be saved?
We do know that most of the time there is some residual function of ovarian follicles, even when it looks dead. Now, if it's frankly necrotic and liquid, that's a different story. But if it's just a dark colored ovary, we do have studies that show that most of these patients will have some residual function.
And the authors actually state that between 91 and 98% of ovaries managed for torsion will show normal size and follicular function after only about 6 weeks time, even if they appear necrotic during surgery.
Those are great numbers. Why don't we take a look at the final article, which happens to be co-written by you, Dr. Ponsky. It's on incarcerated pediatric hernias by Dr. Sophia Abdulhai, Ian Glenn, and yourself.
Hernia is probably the most common thing that a pediatric surgeon deals with, and most of them are elective. They come in with a bulge, and it's reducible, and we take them to the operating room electively to repair it. The controversy really comes in patients that have an incarceration. The most important point is recognition. Patient comes to the emergency room, they will often present with a bowel obstruction or just a pain and swollen, non-reducible mass in their scrotum. Sometimes it could be a hydrocele, which can replicate an incarcerated hernia. If there's any question, one can get an ultrasound. But usually you can diagnose an incarcerated hernia from a hydrocele because you can get your fingers above a hydrocele oftentimes that's sequestered in the scrotum, and you can't do that with a hernia. Also, the hernias are usually tender and painful, and a hydrocele is not. The key thing about how to reduce these is that we do try to reduce these in the emergency room. The general tenet of teaching is that you cannot reduce dead bowel. People get afraid to reduce these because they worry that maybe there's dead bowel and they shouldn't try to reduce it. It's very hard. So to have a hernia reduce if it has dead bowel, usually it won't reduce. So we do recommend trying in the emergency room using 2 hands, one pushing on the external ring downward and one pushing up on the bowel, so you sort of cone it down into the external ring. If you just push from below, it will go up and over the ring and you won't be able to get it reduced. Once it's reduced, there's controversy about when to fix the hernia. And I think we recommend, based on the surgeon's preference, whether they do it the next day or have them follow up electively in the next week or two. We do think that they have a high rate of re-incarceration, so we don't suggest people wait too long. One of the newer ideas is that now that we do laparoscopic hernia repairs, I don't believe you need to have that mandatory waiting period of 24 hours to let the inflammation go down. You can often take these kids to the operating room, even while they're incarcerated, reduce it in the operating room, and then repair it laparoscopically, because I don't believe the swelling makes the operation any more difficult when you're doing it laparoscopically.
Are there any other types of hernia that surgeons should know about?
Fortunately, in children, we're lucky that almost all of them are indirect inguinal hernias. These are from a patent process vaginalis. In 10 years, I have not seen I've seen only one direct hernia. So it is very unusual. There's umbilical hernias, but those are very rare to be incarcerated. I've seen a couple of those, but it's pretty unusual.
I really found the pitfalls section to be rather interesting. Can you take us through some of those pitfalls and what surgeons may encounter?
A rare situation may be that you just can't reduce it, and we wanted to talk about how the surgeon should deal with a non-reducible hernia. What we recommend is making a small incision in the internal ring, which would oftentimes allow the hernia to be reduced. You can usually do this on the lateral edge of the internal ring. The other thing is by doing it laparoscopically, once you induce anesthesia, you can push from the outside and give gentle traction on the inside, being very careful not to tear the bowel. And oftentimes, just with some time in some patients, you can reduce the edema and the bowel can be reduced. The other question is, what do you do when there's dead bowel? This is controversial. There's really no good answer. Some people believe that you can try to do the resection through the internal ring, so out in the groin. The other option is to open up that ring and bring it internally and do it through either a laparotomy or exteriorize it laparoscopically through the umbilicus. This is really surgeon preference and depends on how bad the bowel is. There's also a dilemma about what happens when you're doing an open hernia repair and the bowel reduces without you getting a good chance to look at it. So the anesthesia allowed the bowel to be reduced, but you never saw it. The general teaching for this is that you need to take a look at the bowel, so either do a laparoscopy or laparotomy to look at the bowel. Some people say the truth is if it reduced back in, it's probably okay. This, again, there's no answer for this. It's surgeon preference.
Thank you so much for providing your insight to those 4 articles. Before we wrap up, did you have any final thoughts on this issue?
I think one thing I really like about our group is that we're always constantly asking each other, hey, how would you approach this patient, or what would you do here? And I think this edition kind of takes that approach as to what would you do with some of the most common emergencies and then some of the most unexpected things that may come along rarely.
Emergencies are what give us the most grief, and to have an entire edition dedicated to probably the most anxiety-provoking situations in pediatric surgery was incredibly helpful. And I can tell you that both Aaron and I are incredibly appreciative of the opportunity to put this together. I absolutely want to thank our authors who, I will tell you, these were the key experts in the field without question. And the fact that we got such an all-star cast to write these chapters really makes this a high-quality publication.
Well, we here at Elsevier thank you and the authors as well for your contributions. Thank you for joining us for this edition of the Clinics Review Articles podcast. For an exclusive discount on the issue we discussed today, focusing on emergency pediatric surgery, visit us.elsevierhealth.com/expert. Surgical Clinics is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter at Clinics Reviews and subscribe to the Clinics Review Articles podcast on iTunes and the Google Play Store.